Hello, everyone. Welcome to our virtual conversation focused on what we know about alcohol use and misuse as a coping mechanism. I'm Dr. Carrie Wallenitz with the White House Office of Science and Technology Policy, where I'm the Deputy Director for Health and Life Sciences. And I'm very fortunate to be joined here today by experts who will help us understand alcohol use and misuse and how it's intertwined with other health conditions. But before we start our conversation with them, I wanted to take a moment to set the stage about why we are talking about the issue of alcohol misuse. Today's conversation is the sixth in a series of mental health events that we are running that are focused on the science behind the mental health crisis. This is all in support of President Biden's unity agenda and the goal of tackling the national mental health crisis. Mental health and substance use, including alcohol, are intimately intertwined. Alcohol use disorder often co-occurs with certain mood and anxiety disorders. In fact, having a history of alcohol use disorder more than doubles the odds of having depression, PTSD, or other anxiety disorders. And the CDC estimates that 1 in 4 deaths from suicide involve intoxicating levels of alcohol. Unfortunately, alcohol and drug misuse often go hand in hand. People with alcohol use disorder are 8 times more likely to have another drug use disorder than the general population. And alcohol plays a role in around 1 of 5 drug overdose deaths. One of the challenges for the research and health community to understand is how all of this is intertwined. And so to that end, before we get started with our conversation with our experts, I wanted to take a moment to pass the stage over to my White House colleague at the Office of National Drug Control Policy. Dr. Cece Spitsness, welcome. Cece is a senior science policy analyst at ONDCP, and she's going to give us a little insight into the kinds of trends we're currently seeing in the use of alcohol and other drugs. And then she'll hand it back to me, and we'll kick off our conversation with Dr. White and Dr. Kalec. Cece, welcome.
Thank you so much, Carrie, and welcome to all of you who are participating today. As Carrie mentioned, my office, the Office of National Drug Control Policy, works on federal policy for both drug use and underage drinking. I have 3 things today for your consideration. Number 1, people who use substances to cope cannot be categorized as purely people who use drugs or people who use alcohol. Polysubstance use often involves drugs and alcohol, so people in both the alcohol and drug policy and services fields must ignore our silos and work together. Number 2, in 2020, the percent of Native American and Alaskan natives aged 12 and over who reported currently using illicit drugs was 2 times higher compared to their non-Hispanic white counterparts, 28% versus 14%. But there were no statistically significant differences between these groups in terms of reported heavy alcohol use in the past month, 7%. Number 3, alcohol is a sedative drug. Sedatives and analgesics can interact. ONDCP analyzed changes in a fatality data set that involved both alcohol and drugs overdoses from 2018 to 2021. And in our latest provisional data for 2021, alcohol-related deaths involving synthetic opioids like fentanyl had increased by 146% since 2018. Among people who died with alcohol in their system, 76% of them also had a synthetic opioid present. Our analyses indicate that synthetic opioids and sedatives have been driving the trend for an increase in alcohol-involved fatalities. This drives home my initial point that we must always talk about drugs and alcohol together when we discuss coping. I hope everyone enjoys this webinar, and now I'll turn it back over to Carrie. Thank you.
Thank you, Cece. Sobering statistics. We appreciate you taking the time. So without further ado, I'd like to introduce today's experts for our conversation. First, please welcome Dr. Erin White. Erin's the Chief of Epidemiology and the Biometry Branch at the National Institute on Alcohol Abuse and Alcoholism, NIAAA, which is a component of the National Institutes of Health, which is focused on the effects of alcohol on health and well-being, as well as reducing the effects of alcohol-related problems across the lifespan. Erin also serves as a senior scientific advisor to the NIAAA director. His research is focused on tracking patterns of alcohol consumption and related consequences in the United States and examining associations between alcohol use, mental health conditions, and genetics. So welcome, Erin. Next, we also have Dr. Daniel Kalec. Since 2003, Dan has served as Chief Medical Officer of the Indian Health Council, or IHC, which is a consortium of 9 tribes located in the North County, San Diego. IHC provides on-site and outreach services and programs to nearly 5,000 clients per year. Dan is a physician who is board certified in both internal medicine as well as pediatrics, and is an active member of the Palma Band of Luciano Indians. He leads the California Native American Research Center for Health Project, which is funded by NIH, that provides a platform for community-based participatory research in American Indian communities. He's also been involved in studies on preventing underage drinking in Native American youth. So I want to thank both of our speakers for being with us today, and all of you who have tuned in as well, either live or who are listening to the recording after the fact. Many of you have submitted questions in advance, and thank you for taking the time to do that. We'll try to get to as many of them as we can in the conversation today, but recognizing our time is limited, our plan is to collect them at the end of this series and answer any lingering questions in a blog post. So let's dive right into our conversation. Erin, let's start with you. So of all of the tragedies caused by the COVID pandemic, of which we know there are many, one of the most staggering statistics I've come across came out of your recent paper on alcohol-related deaths during the first year of the pandemic. In particular, it was incredibly striking that in 2020, more people between the ages of 16 and 64 died from alcohol-related deaths than COVID-19. Could you put this in the context of what we're seeing with alcohol use in and during the pandemic?
Sure, and thank you for having me. Well, it was an interesting time for us in alcohol research and public health before the pandemic, because for about 2 decades, we were watching an increase in alcohol use among adults, particularly women, an increase in drinking by older people, and an increase in harms related to that drinking. So we were seeing pretty consistently year after year increases in emergency department visits related to alcohol, liver disease cases and deaths, and other deaths related to alcohol. And again, these increases were bigger in general for women. Interestingly, there were actually decreases in alcohol use among our young people, which is very encouraging news. But we also saw a shift beginning in alcohol use among young people away from drinking to socialize and more toward drinking alone and drinking to cope with stress. And so that's sort of where we were before the pandemic. And then, of course, the pandemic started and everything escalated.
Thank you. Dan, if I could turn to you, it's one thing to talk about statistics and numbers, but really it's about people and the effects that this has in communities. You're on the ground seeing patients with the IHC. Can you talk about some of what you've seen? What are the differences during the pandemic, leading up to the pandemic, what you're seeing now in terms of alcohol use and effects with your patients?
Thank you for that question. And I think it's imperative to recognize the fact that my expertise really comes from not only working with Indian Health Service and participating in organizations and communities across the country and seeing these same issues across the country in many different communities, not only American Indian, but also intercity Latino communities, but also working closely with the NIAAA on the advisory council and working closely with individuals like Erin White. But with that, the respect to alcohol, all communities have really been affected. I think even before the pandemic, with the legalization of marijuana and the advantages that social media and internet provides with respect to anonymity and the accessibility to items such as food and items to purchase such as alcohol, a person really didn't need to go anywhere to get anything. And I think the pandemic with some of the lockdowns really exacerbated that issue. in a recent publication looking at the efforts to curb underage drinking that was done in California, there was definitely an improvement with the use of multi-level interventions. And that's something we've seen not only here locally in California, but across the country, where you incorporate many different levels of interventions, whether it be community levels, state, county, national levels, to really get the word out. And I know we're going to talk about a couple more of these interventions in the questions to come.
Great, thank you very much. So as you just alluded to, the pandemic really turned our society on its head in many, many ways. Massive changes relative to this conversation. Of course, there was closure of bars and restaurants in the early days of the pandemic, but we also saw the introduction of more or different kinds of stresses into people's lives. Just speaking from my own personal experience as a working mom who is trying to handle working from home with 2 kids, homeschooling, and all of the demands of trying to keep the family safe and healthy in the pre-vaccine era. It was overwhelming, to say the least. And I know that the research community is still unpacking that as we're still in the midst of a pandemic. But I was hoping each of you could address what the research says about the changing reasons and context behind why people are drinking or why people might be using alcohol as a coping medicine. For example, I saw one study that indicates that young people are drinking to relax and relieve tension due to stress or to relieve boredom than in prior years. So Aaron, maybe we'll start with you.
Yeah, thank you. Well, I think as with all drugs, people use them for different reasons. Some people drink alcohol because they like to socialize and party. Some people drink alcohol because they're trying to cope with anxiety and overall stress. Some people do both at different times. But leading up to the pandemic, we were seeing a downward spiral in our general mental health in the United States. And so we already saw signs of increases in substance use, including alcohol use, to try to cope with that. And then the pandemic came and it added a huge amount of stress to all of our lives. And so it's not surprising that we saw what we saw, which is more people, in an effort to try to contend with the anxiety and uncertainty of the pandemic, started drinking more because it works temporarily until it stops working. But it is initially can help people dampen those feelings of stress and worry. And so again, whenever we see a national crisis, something like this, although this hasn't happened per se, we tend to see people move in 2 directions. Some people drink more and it's generally to cope, and some people drink less and it's generally because it's an expense that they don't have the funding for, and alcohol is not a big part of their lives. And so I think that's what we saw. The research tells us that of people who started drinking more during the pandemic, it was generally in an effort to cope with the uncertainty of the pandemic. And so that's sort of where we are. Again, we were already on this path before the pandemic, and then the pandemic just cranked it up a bunch of notches.
Yeah, Dan, I see you nodding. Does that match with your experience as well? And I know you work a lot with kids. What are you seeing among young people in this vein?
Mr. White and yourself actually bring the point to bear. We're all on the same page in terms of how alcohol has really affected the population, the community as a whole. And we know it's well documented that risk factors for consuming alcohol at ages less than 21 or before the brain is developed fully really predisposes risk for alcohol dependency. So and coupled with the additional normalization of alcohol consumption that we've all kind of seen throughout the country, also places additional risks for groups to engage in risk behavior, especially in adolescents, when we're known to maybe engage in risky behaviors that we're not really accustomed to dealing with. As we've seen and discussed already, the epidemic has really modified and magnified these risk factors by introducing stress and pressure, maybe to succumb to these risky behaviors. I think the last 25 years, for some of us, actually most of us here on the phone call, we can really attest to the fact how social media, how the internet, how instant information has really changed our lives, where we're really getting used to growing up with it, whereas people and the previous generations have actually grown and known it for their whole lives. And so for us in this generation, we're still getting used to this whole process and how to deal with these problems that come up on a regular basis. It's interesting that you mentioned the stress of the pandemic, because it's exactly what children and adolescents are kind of growing up with and what they're kind of getting used to. Suddenly we have them, they have to contend with how to manage instant information and instant judgment and critique. If we are less than 5 stars, then we're considered less than, inferior, and in some extreme cases, bullied. So it would be remiss not to consider the significant stressor, and similarly, not to consider that some of us may turn to substance abuse, may manifest depression, or even attempt to hurt ourselves or others. So it's really kind of reading the writing on the wall that we've seen over the past 10 to 20 years.
Thank you. Erin, I'd like to just reflect for a minute on this connection between mental health and alcohol use and misuse. So as we touched on in the beginning, we often see alcohol misuse hand in hand with other mental health conditions, such as anxiety disorders. And as both of you have said, you know, it feels like in the moment, alcohol is a solution to those conditions. But what do we actually know about that? What does the science and the research tell us about the relationship between alcohol and other mental health conditions?
Yeah, well, the relationships are complex and they seem to work both directions. That is, you could develop a mental health disorder, anxiety problem, depression, PTSD, and then the drinking can follow that in an effort to try to cope. And the drinking can then worsen the condition. And sometimes the drinking comes first, but there's a bit of a trap here with alcohol, and that is it works really well at temporarily dampening activity in brain areas that make us feel afraid. You know, there's an area of the brain called the amygdala, which is basically like your smoke alarm. And when it detects smoke, it starts chirping, and the smoke is danger. It's a threat to you in some way. And that threat in the modern world could come from a dog barking. It could come from an insult on social media. I mean, there's all sorts of things that threaten us. And so the amygdala is constantly chirping and going off. And we don't like that because it doesn't feel good. And so alcohol temporarily dampens it, and it makes a promise it can't keep. And the promise is, hey, just drink me and you won't have to feel these uncomfortable feelings. The problem is that the batteries don't stay out of the smoke alarm. They go back in when the alcohol wears off, and the smoke alarm gets louder. And so what I'm fumbling around with metaphorically is that drinking initially can dampen that discomfort, but ultimately it makes that discomfort worse. And so then you end up drinking just to try to fix discomfort caused by changes in the brain resulting from the drinking. PTSD is a great example. If you have PTSD and you've got high levels of anxiety and fear and sleep disruption, sleep disturbances, alcohol might help you initially. But the changes in the brain that happen when you drink regularly actually end up making the symptoms of PTSD worse. And so the anxiety gets worse, the sleep gets worse. So it really ends up being a maladaptive coping strategy. And so we feel at our institute, one of the ways that we should help address problems with alcohol in the country is to make people aware that there are other ways to cope. It doesn't have to be alcohol. Find a relationship with some other strategy for coping with stress and anxiety that doesn't carry the same risks.
Thank you. I love the neuroscience metaphor of the smoke alarm. And actually, that's a great segue into talking about prevention for a minute. Dan, what are some of the evidence-based practices that you use when you see patients that can prevent alcohol use or maybe prevent people from progressing from alcohol use to misuse or to prevent alcohol use disorder?
Thank you for that question, Carrie. And I want to say first that I'm not a neuroscientist, and I was in awe of the neuroscientists that came to present their information and their data when I was sitting on the advisory council right along with Mr. White. The processes that are involved with the issues of addiction and repeat use are very complex, and it's a great thing, and it's a great research that's being done at NIAAA in conjunction with NIDA, National Institute of Drug Abuse, that really highlights a lot of the innovative therapies But some of the stuff that you can do in the moment, and I like that little comment you had mentioned, or Dr. White had mentioned, in the moment. And so, much like in the moment in terms of turning to alcohol for a quick fix, in the moment a quick fix that has been shown to work is the use of motivational interviewing, the use of the screening and brief intervention and referral for treatment right when the patient is there. So those evidence-based measures where you have the client in front of you and you have the opportunity to really make maybe even a couple words, spend an extra couple minutes to either use your tools for motivational interviewing and or provide a little bit of psychoeducation in a collaboration with a behavioral health unit that is hopefully on site. And that's some of the research that we've done here within the NARCH component, the Native American Research Centers for Health, that, as you mentioned, was and is NIH funded, that psychoeducation, motivational interviewing in response in collaboration with the screening and brief intervention referral for treatment with behavioral health collaboration really can make a difference in helping people cross over that line to effectively change their behavior. So, and that can be done, again, on a regular visit as a walk-in. It can be done as a preventive visit during well child care or during adult physicals. And it's just an extra couple minutes. So it's so important that providers who are on the front lines really look to NIAAA and what they have to offer, because they do have a great plethora of information on their websites and the research that we first alluded to that they're putting out on almost a daily basis.
Great, thank you for that. So something that Cece brought up in the beginning of this conversation was that intersection between alcohol use and other types of substance use. And before we had a COVID pandemic, before we started talking about the national mental health crisis, our country was in the midst of a tragic epidemic of opioid use disorder. And unfortunately, that has not gotten any better as we've coped with these other challenges. I'd love to hear from both of you on some of the common drivers behind challenges with mental health, alcohol use, substance abuse, and maybe the flip side of that, the more hopeful side, is does getting help or treatment for one of these things help with the others? And you know, what does that look like? You know, both from the science side and you know, what is happening on the grounds with seeing patients. So, Aaron, maybe we'll start with you and then turn to Dan.
Sure. You know, I think that to really get a handle on something like the overdose crisis that we've seen, and again, alcohol plays a significant role in those, I think we have to take a step back and ask where that's coming from. We can't just prevent something from happening at the end step. We need to ask what is driving this at the beginning, and it's just too much to discuss in this brief meeting. That's a complex issue, but I think with alcohol, we know that that when people go to their doctors, if a doctor were to ask one question about alcohol, they could get insight into not just alcohol, but the mental health of the patient. For instance, if somebody comes in and you ask them about their drinking and they tell you that they binge, for instance, you know, once every month, you'll find that they're statistically more likely to have major depression, to be suicidal, to misuse opioids. It doesn't mean that they absolutely do, but it means that a simple question about alcohol can actually clue healthcare practitioners into other aspects of people's lives. If there's one thing I could wave a wand and change, it would be fixing the problems with the continuation of care. Continuum of care in the United States. A lot of people show up to doctors' offices. Most people see a physician every year. And they're asked about basic health-related things, and their vitals are taken, but they're not asked if they're suicidal or if they're drinking too much. And each one of those visits is a missed opportunity for routing somebody through to appropriate care for whatever it is that they need. Obviously, being suicidal is a threat to health. Obviously, having an alcohol or other substance use disorder is a threat to health. So I think beginning to recognize these issues as real health-related issues, not just secondary to physical health, would really help. And so we're working on that. We are trying to promote the use of screening and brief intervention and referral to therapy. In a perfect world, every person shows up to a doctor, gets asked a few basic questions about their mental state and their substance use. Yes, it takes time. Yes, it takes money. These are some of the hurdles. Doesn't mean we shouldn't do it. So I think a lot of people are getting missed at multiple times in their lives where we could have intervened and altered the trajectory. So I think that's part of it. And we have lots of resources. Dan, thank you for mentioning some of our resources. We have several resources that we think are helpful. If you think you might want to learn more about your own relationship with alcohol, or somebody else that you care about their relationship with alcohol, we have a resource called the NIAAA Rethinking Drinking website, which helps you explore your drinking and decide whether you need some support. And if you do need some support, we've got a website called the NIAAA Treatment Navigator, which helps you explore types of resources and locate them in your area. We also just finished a large compendium of resources for healthcare physicians called the Healthcare Physicians Core Resource to help physicians get the background material they need to start doing basic screening and referral to treatment. So there's a lot to do. I think we can do it. I think that we need to focus closer to where the problems begin and not just wait until the problems reach ahead, like a suicide or an overdose.
Right, some great resources for those who are seeking them. Dan?
Thank you, Dr. White. Really hitting the nail on the head. And it looks like we almost met before this phone call to really kind of go over the same resources that are available. I'd like just to reiterate the importance of the Treatment Navigator, the Behavioral Health Treatment Health Navigator, a fantastic resource, very uncomprehensive and a great resource for individuals. But to Dr. White's point, it's really getting the word out, and whether it be asking those questions, being more aware about what's going on with patients, because as you alluded to, Carrie, things are not really getting better. And this is despite a lot of financial support, education already that's been put in place. But with the ever-present methamphetamine that is in a lot of our communities, with the pandemic and the risky behaviors, the fentanyl opioid crisis that is still flourishing, it's easy to understand that there's more work to do. I was lucky enough to participate in one of the 2016, 2017 opioid pandemics that was held in Atlanta. And there, then President Obama was very prophetic in saying that the rural areas were going to be hardest hit when dealing with this opioid pandemic for a variety of reasons. One was the issue of information access, the internet, geography, the ability to provide law enforcement and support for individuals to manage these items. And it's a well-known issue that's where a lot of people are really being untouched in some of the rural areas, and those people who lack technology access. But day to day, we have found three important factors that really need to consider when faced with these challenges. There was a component of the holy trinity, or the deadly trinity, with Percocet, Xanax, and opioids. And it's time to rename that. They're looking at the trinity of patient-centered home, where they have patient-centered home with behavioral health integration and cultural supports that can really facilitate a better conversation and support that a patient may already have. That cultural support may be American Indian, it may be Latin-based, it may be religious, but it's important to really kind of provide the person with an awareness of some of those supports so they can turn that corner and utilizing the expert that Dr. White had mentioned and making that appointment with a behavioralist. We have found that some of the studies we've done through the NARCH program involving the cultural component of American Indian culture provides a very resilient component to their ability to withstand and recognize the dangers that exist in their day-to-day lives. So I think it's important to really bring in that whole team that not only includes the medical part of it, but also the behavioralist and even their pharmacy and dental components. I mean, it's a whole body system that we really need to recognize that needs support, not only one part, like the medical component.
Thank you, and thank you for reminding us of the important point of cultural context. Really, really critical. So we focused on a lot of negative things in this conversation, a lot of scary statistics, but I'd like to sort of bring us to a close on a note of hope and ask each of you, what are you hopeful about in this space? What do you see on the horizon, whether that's in trends or prevention or treatment or opportunities in the science that really makes you hopeful for the future? So Erin, maybe we'll turn to you.
Oh, sure. Yeah, there's several things that give me hope after just spending 20 minutes telling you all the things that concern me. But we've seen some really encouraging things happening with regard to alcohol and public health. You can have things move in good and bad directions at the same time. There's no question about it. So while we did see an increase in alcohol use leading up to the pandemic, and I forgot to mention to you all just how big the increase in alcohol use was during the pandemic, even though bars and restaurants weren't open for a lot of that time, alcohol sales increased more in 2020 than at any time in the 50 years previous. And so people were drinking a lot more. And again, presumably largely for coping. But at the same time, we also were seeing before the pandemic started, a real groundswell and interest in opportunities for being mindful of one's drinking, taking a break like Dry January, Sober October. I think each month has one of those now. The Sober Curious movement in general, which is just about sort of thinking about your drinking and your relationship with it. Clearly, there's been an increase in sales for the beverage industries in low and non-alcohol products. That's a big growing part of their market. Something is shifting with regard to sort of public orientation to alcohol itself. So that is encouraging news. And the other thing is that I think this pandemic, it gives us an opportunity, particularly, hopefully it's starting to slow down, but it gives us an opportunity to talk about ways we could cultivate better habits, better ways of coping with stress and finding joy in life. Get back to the basics. When people feel connected to their families, when they have a sense of connection to their history, to their communities, they tend to be more resilient. And if they're more resilient, they tend not to fall into these sorts of traps of leaning on substances that offer quick fixes. And in exchange, they try to find healthier, longer term ways of coping. So I see changes that are very promising, but they're just sort of embers right now. We'll have to see what happens. But I think we can build on that and help build resilience, promote healthier alternatives to drinking to cope. And we could certainly find ourselves in a very different place in 10, 20 years.
Dan, do you agree? Are you feeling hopeful too?
I really echo those comments, because if not for the lemons, we really wouldn't have any lemonade. And I think that's what the pandemic is really kind of bringing to the forefront. Without it really shining a light on some of these issues that have been persistent for decades, it really shows us that there is a huge problem with alcohol use disorder across the country. There is a huge order with substance abuse, whether it be fentanyl, opioid, or methamphetamine across the country. And I think the allocation of the American Recovery Funds to really highlight COVID, the outreach, the individuals that are now going out into homes to provide those services and follow-ups for not only COVID, but also the other comorbid conditions like alcohol use disorder that coexist with the reason they may have actually had COVID because they were in the home in close quarters with their loved ones. So really looking on the other side of the mirror, I think there's a lot of great starting points that we have here as the pandemic hopefully winds down, and we can actually start with some better steps forward to really address a lot of these problems that have, again, persisted for decades.
Thank you so much. Well, I think we could probably continue this conversation almost indefinitely, especially if we stay on the good news vein that we ended on. But I wanted to take a moment to thank you both for not just joining us today for this important conversation, but also for all of the work that you're doing. And I also wanted to take a moment for our audience to highlight a resource provided by our partners at the Substance Abuse and Mental Health Services Administration, or SAMHSA, as it's better known. They actually run a national helpline for individuals and families who are facing mental and/or substance use disorders that provides information and treatment referrals. It's free, it's confidential, it's run 24/7, 365 days a year, available in English as well as Spanish. So you can call 1-800-662-HELP, that's 4357, or search online for SAMHSA's National Helpline. And I should also note, for anyone in crisis, you can also try the new National Lifeline by just dialing 988. So both of those resources are available in addition to the ones that we've talked about today. So we are going to take a pause on our series for a few weeks, a mental health break, as it were. But we'll follow up for everyone who's registered and watching by email with the link to the recording of today's conversation, as well as all of our past events. And you can keep an eye on OSTP's website, our events and webinar page, or follow us on Twitter at WHOSTP for more information. With that, thanks again, Erin and Dan. Greatly appreciated you taking the time. And thank you to our audience for tuning in. And with that, we'll wrap up today's webinar.